Good afternoon, everybody. Welcome. It's the 13th of March, with the meeting of the NHS Lancashire and South Cumbria Integrated Care Board. We've a number of apologies for today's meeting. Medical Director Dr. David Levy, partner member Aaron Cummins, and participant member Vicky Gent. Good to see everybody. Usual rules on declarations of interest, please. It's complex business with multiple partners and agencies involved in the work that we discuss here, so please, as usual, just raise it and speak out if you feel conflicted in any part of the discussion or wish to declare an interest at that point. In terms of things across Lancashire and South Cumbria, I want to mention and put on the record and congratulate Chris Oliver on the Lancashire and South Cumbria Foundation Trust, where Chris is the Chief Executive, recently been inspected by CQC and come out with an overall assessment rating of good. We know in the past the Trust has had a complicated and difficult history, and in the previous inspection had been rated as requires improvement. Well, the improvement it required at that time has been made and exceeded indeed, Chris, and it's a testament to the work of you and your board and the team. And please, I've spoken to David Fillingham, your chair, but please pass on as well the congratulations from this board, and come back and let us know when you'll be moving to outstanding. also to announce that at Blackpool Teaching Hospitals Foundation Trust, the Chief Executive there, Trish Armstrong-Child, has announced that she's retiring after 35 years of service. Trish has been there since the autumn of 2021 and has done a terrific job in a very, very challenged place. Outstanding Chief Executive, Trish, and Kevin and the team here will be working with the board there to find a new chair and a new chief executive. I wish Trish all the very best going forward, and a long, happy and healthy retirement. And our Maggie is going from here to take up the role of chief executive starting next month, and you'll be really missed around this table, Maggie, of course, but still be part of the system, still be part of the team, and we wish you well with that. As you may have seen announced previously, this will be my last meeting as chair of this board. I've taken up a post as chair of the Liverpool University Hospitals Foundation Trust and Liverpool Women's Hospital, and after the meeting today, I'll hand over to Roy Fisher, who will step into the role of chair, and in parallel with all of that, a recruitment process is I think in train now. Right, we've got our minutes of the meeting held on the 10th of January, please. Are there any points anyone wishes to raise on those minutes, either of substance to carry into today's meeting if it's not elsewhere on the agenda, or matters of accuracy? Thank you. Can we approve the minutes, please? Okay. Thank you, Roy. And on the action tracker, Company Secretary, anything I need to pick up that isn't on the agenda? Okay, thank you. We have received, before I get into the agenda, we've received a number of questions from members of the public regarding primary care GP practice commissioning and some access to dental services. These questions will be addressed in more substance at the Primary Care Commissioning Committee, the next meeting of which is tomorrow. So we'll feed all of that back to the people who've raised the questions and follow up after the meeting tomorrow. Right. Let's move on, and we're straight into Sarah with the patient story.
Thanks, Chair. Before I introduce the story, can I just also say there was a couple of actions around maternity for me on the action log. So in terms of the update on the MIS, there's a paper going to Quality Committee next week, which Louise is going to circulate to board members after this meeting, so you can see the update there. And David and I did meet around advocacy, so I think we can close that action as well. It's just for the record, really.
Thanks, Sarah.
The patient story today, before we play it, I just wanted to put a little bit of context. So it's slightly different in the way we're presenting it than previous ones, because it's not the patient or their family speaking. It's a community worker who's working for one of our community organisations, who's sharing the experience of a family around a child who was newly diagnosed with asthma. But I think what the story really brings out for me is, so childhood asthma is a real challenge in populations like ours, and it is one of the national children and young people's transformation programmes that we get some development funding from NHS England to deliver locally, and we are doing a lot of good work around asthma prevention and early diagnosis and treatment of asthma across our children and young people around Lancashire and South Cumbria. But in particular, what today's story brings out is how we're working closely also with one of our community organisations to help us provide some of the support on these pathways. So I hope it's a welcome story, not only because it focuses on asthma, which is a challenge for us, and the good work that we're doing, but also it shows some close working with one of our voluntary sector organisations, which we've talked about a lot at board. Thank you.
The most recent patient stories that I was privy to was a local lady in Blackburn with Darwen. She was attending a group with one of our host charities, which is One Voice Blackburn. The champion in question was delivering a session on asthma awareness raising, and she could see in the audience a member having a chat with the lady next to her in Urdu. So she left it at that point, carried on with the presentation, but at the end approached the lady, had a chat with her about what she was discussing. Was there any issues? Was something she could help with? She raised that she had a 3-year-old son who had been in and out revolving door of A&E and GP services with repeated chest infections. As a consequence, her son was missing quite a lot of nursery, and obviously the socialisation aspects of that. And she was concerned, so the champion had advised that she went to a GP. She explored the possibility of asthma, and from what the lady was telling the champion, it sounded, to all intents and purposes, that it was asthma. There was the raspiness, the wheezing, all of that comes with the condition. So the lady did attend a GP. She was given an asthma diagnosis for her son, equipped with the correct medication, aftercare. She fed back to the champion that, this was absolutely fantastic. She was so glad she'd attended the session. And yeah, little boy is now attending nursery successfully and has an active participation in that. The joy of this project is that it's peer-to-peer support. It's not a professional mandating, telling them exactly what they need to do, what they need to change. They are there, the clinical services are there to support, but they've got community members who may have experienced this, have knowledge of it, are empowered to inform them of the correct steps to take and signpost them to the correct agencies and help them in that way. And I think this is more, I suppose, taken up by the community because of that fact.
The last thing I would say is using a system like that with peer-to-peer support and with people who know the local community means that through that programme we're also really targeting it in the areas of inequality and the areas where we know that because of maybe cultural challenges or inequalities in that area, people might not go to the GP as easily as other people would. So I hope you welcome that as a really good example of not only some of the good work we're doing on childhood asthma, but how we are working in a more focused way with local communities and with, in that particular case, with Spring North.
Thank you, Sarah. Points, questions, thoughts? Please, Jim.
Thank you. That's really good. To what extent is that widespread across the patch? That was Blackburn with Darwin. Is that happening everywhere? And is it a service that we need to expand? I suppose that's the question, really.
Yes, so it is part of our Children and Young Persons Transformation Programme for asthma, so I wouldn't like to sit here and say it's happening everywhere, but it isn't only happening in Blackburn. The team are rolling out initiatives like that across the patch. At the moment, quite a bit of the funding comes from what isn't necessarily always non-recurrent. It's often non-recurrent funding that comes in year on year as part of some of the national programmes around children and young people, and that's how we're managing to fund it.
Thank you, Jeff. Next, and then to Tracy.
I think it's a really good example of where, as a GP, we really appreciate if someone comes with a question that's well informed, which is what this third sector organisation managed to do. You know, it was really good a few years ago, probably a decade ago, when we had the antibiotic campaign, and patients were coming in saying, "Are you sure I need that antibiotic?" Which is really good. So I think we should try and encourage this type of. I mean, because we're sensitive cells, we don't like being told, "I know my child's got asthma and I want the treatment now." That's a bit too direct. But if someone comes in with a targeted question like that, it's really, really helpful.
Thanks, Jeff and Tracy.
Thank you. Thank you for bringing that. I think, you know, you'd obviously think that I would be really pleased to see that. Really great to see Alicia from Spring North as well, talking so eloquently about the service. I think Jim raises a really important point about the probably lack of consistency of services and the way in which funding often leads to a lack of consistency. I think that really highlights it, doesn't it? Because if you think about that peer-to-peer support and how important it's been, and how there's so many barriers to communities, whether it's through language or other reasons, to access community services, and the difference that support within the community makes, it's obvious to see when Alicia describes it. I'd like to see us think about how we can join things up a bit more and make sure that a community in Blackburn that benefits from this, or people in Blackburn that benefit, can also be, the benefits can also be seen in other places. And I still think there's a long way to go on that work.
Thanks, Tracy. Sheena.
Thank you. It's a really helpful reminder of the importance of thinking about how do we really get into communities, come alongside people. My observation was more of a sort of a more broader picture one, and I think it was like what was making me sort of sparked my bit in it was around the repeated attendances at A&E with the respiratory infection, and I was kind of thinking that's also in a parallel thinking around taking our population health based work that actually says let's start to look at some of the pictures, where have we got that, and thinking about how do we take, you know, that broader population, look at it, use our intelligence to actually say, are there particular groups or communities where we need to think about how we might do alongside communities, the advocates, the champions work, to actually think about how we might help people get even better outcomes rather than it being reliant on somebody have gone to a group. So that was just kind of my overarching thinking about how we can add even further value, and another dimension as being taking a population-based system approach
Very
as an
good.
ICB. Thank you.
Very good, thank you. Okay, excellent. Well done, Sarah. It's very good. Stimulating our thinking. Chief Executive's report, please, Kevin.
Good afternoon, everyone. Actually, today marks 2 years at the ICB for me, so I thought it would be a good time to reflect on what's gone well, what still needs to be done. It's definitely been a bit of a wild roller coaster ride at the Blackpool Pleasure Beach. Certainly not for the faint-hearted. We were born in the immediate aftermath of the pandemic. in the midst of a cost of living crisis, with a new period of austerity, declining health outcomes. They've gone backwards over the last few years, as you know, an unprecedented increase in demand for health and care services, and increasing complexity with many patients presenting in A&E, and a huge backlog of cases. Locally, it is worth reminding ourselves, we were the hardest hit region by COVID, and that has some ongoing effects. And we probably don't fully understand what all of those are yet. We haven't worked out all the patterns. We inherited a postcode lottery of service standards. We had low to middling performance in a lot of areas. Our staff worked miracles during COVID, but frankly have been tired through all the efforts. And they faced a long period of uncertainty about whether or not integrated care was actually going to happen or not. And then when it arrived, there was reorganisation, there was change, and a 30% cut in running costs, even though they'd been told the jobs would be safe. Financially, you know, our position is very challenged, but it's not new. Probably the difference is that we're being upfront about it and we're facing up to the issues. But it is worth summarising the financial challenge we face. In 2019, our providers had deficits of 170 million in 2019. In quarter one of 22-23, we were gifted 150 million deficit from the CCGs, and we faced very high inflation over the last 2 years with standstill budgets. Not all of that inflation has been funded by NHS England. Not blaming them, it's just the difficult times we are in. And we've also had quite a lot of unfunded mandates as well. That's a figure north of 100 million when you look over the 2-year period. We got extra monies because we were badly hit by COVID as a region, and our providers correctly invested that money in extra beds and wards, and the staff needed to support those extra beds and wards because they were subject of unprecedented demand. That money's now being withdrawn, but actually the demand for the service remains there. That's another 100 million plus problem, and there's still more of that money to be withdrawn in future years as well. So that, when you saw the headline about the 10% difference between the level of service that we're providing and the available funding envelope, that really explains it in a very, very simple way. As a chief executive, it's quite frustrating to spend so much time on the money. It isn't really the thing you get out of bed for, but we do need to have a stable and sustainable financial platform to do all of the good things that you do want to get out of bed for, like improving services, improving health outcomes, and narrowing inequalities, and innovating to do things faster, better, smarter for our patients and the public. There are reasons to be cheerful. In the most challenging circumstances, performance has remained really quite strong. We're actually an upper quartile performer on most key NHS England metrics, and we had an extremely challenging winter yet again, but I thought our system, including our colleagues from local government, performed very, very well in trying circumstances. We have seen some very significant improvements in performance across the system. The chair just referred to the CQC rating for LSCFT, and I add my congratulations there. But we've also had University Hospitals in Morecambe Bay moving from SOF 4 up to SOF 3, and on a good trajectory, I think, to get to SOF 2 in hopefully a short period of time. I think we've managed expectations well across our system. We've been upfront about the challenges throughout. And we have got a plan agreed with NHS England. In all of those discussions, nobody has said we've missed something out or we've got it wrong. So I think that you know, that all bodes well for the future. I think there are some very encouraging green shoots for the future of recovery. The first one is about no surprises, really. NHS England have never liked the numbers we've been forecasting in terms of our outturn, but they've actually been steady from the beginning of the year and all the way through the year. And we are at risk of going slightly off plan at the year end, but again, that has been flagged up throughout, and there have been full briefings on that. That's fundamentally about no surprises, and it's about trust and confidence. The underlying cause of the deficit is really, one of the issues there is around the staff who were recruited for those wards and beds I mentioned earlier. We had about 7,000 staff who have been recruited since 2019, and about 2/3 of those are not now funded, is the truth of it. Nationally, in 23-24, there's been a 3+ percentage growth in the workforce. Ours is plateaued, so that's a green shoot of recovery. It's plateaued. And if you take out the growth in the ambulance service, the MIS, and the acquisition of ELFs, it's actually a modest decline in the staffing numbers for the acute trusts. And next year, we're forecasting a reduction over 1,000 posts in those acute posts, in those acute trusts. So that's a significant, we have to do that if we're going to bridge that gap that I mentioned earlier. For central services, this is an important project that we supported at our first business meeting in July 2022. It's a big project. It's been hard going. It is now happening. In May and June of last year, the Provider Joint Committee agreed to proceed and press the button with that project. In September, East Lancs Hospital Trust was named as the host of that project. In December, a single collaborative bank went live. In March, on March the 1st, a managing director was appointed from within the system to run that centre. And in Q1, we're expecting 4,000 staff to cheaply transfer into that organisation. So it is real, it will be bumpy, there will for sure be twists and turns, but there's a very big prize, which is having a modern 21st century platform to support health and care services going forward, and a £70 million annual saving in full year effect. And next year, 28.5 million is the figure, which is very, very significant. Next area is clinical reconfiguration. When I arrived, it felt a bit like lots of talk, but not so much action. That's changing. We now have programs for 3 fragile services and 4 clinical networks that are real projects with detailed plans and project support. And it's fundamentally about addressing the postcode lottery in those areas, about improving patient safety and quality, and a byproduct will be some financial efficiencies too, and it's significant, £30 million in year 3 per annum. So that's significant, and there's much, much more to come in the months and years ahead. Final area is, second penultimate area is place. We have had to adjust and improvise our place programme going forward, or to use the modern parlance, to pivot place to make it really relevant to recovery and transformation. We're now developing clear plans for place for a joined up approach and ambitious approach to admission avoidance, to discharge management for our places, for our hospital catchment areas, and for our priority wards. And we're also building a broader, longer term plan for community transformation which we will make sure we cover in a future board development day for the board. And finally, staffing. We've had the staff results for the ICB itself and indeed all of our trusts. They've been made publicly available. Last year's results weren't exactly flash. This year's results remain pretty poor, I think. I think we should be doing a lot better. But we are starting to see some improvements coming through. And whilst many other ICB staff results, frankly, are collapsing. So we are actually an improver. I don't want in any way to be to be celebrating that, because I think we should be doing a lot better than we are, but it is moving now in the right direction. But in the words of a Chinese proverb, a journey of 1,000 miles begins with a single step. So tough times, massive challenges, amazing opportunities, the green sheets of recovery. So yeah, happy to answer any questions, Chair.
Thanks, Kevin. So a lot in there. In the report, thoughts, questions, observations? Yes.
Thank you, Chair. So yeah, it's more kind of thoughts, I think, and really great to hear about the green shoots that are coming through. That's really good to hear. I think I just wanted to pick up around the financial challenges. So we're facing financial challenges, aren't we, right across the public sector, and I guess it's just that reinforcing in that plea that we work together on this in an integrated way. And I think there are some opportunities when we look at place. I mean, I think I see from a DAS perspective some of the things emerging at place potentially might be things that the local authority is already invested in or has responsibility around. So I think if there's any duplication or opportunities where we can do things once, that would be something that I'd be really keen to pick up on and certainly talk about back in place with our place-based directors. Thank you.
Thanks, Kath. And I think the whole purpose and the fundamentals of integration are that we would join up those things more effectively. I mean, it is hard work, as we know, and as we've reflected here many times, but yours is a good challenge. We should be joining into things that are already there and already working wherever possible. Jeff?
Is that working? Yes, thank you. I think just to pick up on the thing you said about challenging times and workload, I think you know, my profession and all clinical professions across all specialties would be really appreciative of that comment, recognising that they've worked in an outstanding way over the last 4 or 5 years. That was on top of austerity that preceded all that, and they're having real tough times. So sometimes I think they can feel that we're a bit detached at a board level, but I think people around this board do really care about everybody who works, and I think the populations benefit from the hard work and commitment of all our colleagues. So I'd just like to pick up on that, and thank you for saying it.
Thanks, Jeff. Okay, all good. Thank you. And sets the scene for some of the discussion that we're going to have, Kevin.
Just to come back on one thing there, on the workload, the thing that strikes you most about the staff survey is a very clear message coming from our staff that we've lost people, but we've got more than ever to do. So I think that's probably a sector-wide, public sector-wide challenge, isn't it, for sure. And you know, the reality is we're not going to get more money, so we have to work with our staff to figure out how we reduce that workload, how we work more innovatively, don't we?
Okay, thank you. Let's move on. Board Assurance Framework and Risk Management Policy. Sam.
Thank you, Chair. Good afternoon, everyone. What we've got here is the regular report that's brought to the board on the Board Assurance Framework. So I won't go through the detail because I think people are familiar with a lot of its content and what it's here to do. But as a new statutory organisation, the big focus in the first year of the ICB was to establish all of its risk management processes and to ensure that the ICB is well governed and managed and mitigates its risks. And I think it's been, at the end of last year, we were in a position where we've done a lot of good work, but it wasn't yet embedded. I think this report does show now we've got a lot more of those processes now fully embedded into the organisation. And this report shows that the work that's been done includes a board session on the appetite to risk, which is built into the papers. It describes the fact that all of our committees now have the opportunity to review the high level risks in relation to its own agenda. The execs have undertaken a full review of the BAF, and one of the things that isn't reflected in the Board Assurance Framework paper here today is a very recent piece of work we did last month as a group of executives to review the consistency of scoring, how that works, and whether there's anything else that we should be thinking about that perhaps, because a lot of the risks on the Board Assurance Framework come from very much a bottom up of things that happen. What we often forget to do is that more strategic look against what's going on outside of our organisation, that horizon scanning, and we took the opportunity to do some really good work on that. It was a really good session. We haven't been able to update the BAF for that because the next stage of that is to bring that to the full board for a review, and we've got a workshop planned in April, so it's just to bear that in mind, but there's some good work going on in there. So we will be reporting back again in July, and the risk appetite work has been fed into the risk management strategy and the policy that's now here for approval today. So as I say, I'm not going through the detail, but there are a few changes to risk and some updates in the paper today. It is really important we get this right, because as we've talked about before, this drives our board agenda because it links to our strategic objectives. So what it does as a tool, it says these are our strategic objectives, these are the risks against it, anything that isn't particularly going to be delivered or we feel that there's a risk against actually delivering that strategic objective becomes a focus for this board to concentrate on so we can stay on track. So it's a really important document for us. So I'm happy to take any comments. I'm not going to go through the detail, but if anybody has any particular questions, I'm happy to take those, or indeed other executives around the room that are leading on their particular areas.
Thank you. Start with Debbie.
Thanks, Chair. Thanks, Sam, for the update and for the work and the great deal of assurance, both in terms of the framework, but also around it being a live document that's being used, because that's where the value is, isn't it? That it's a live framework that's supporting decision making and oversight. I think one of the things that I'd really welcome when we come together as a board to do the development session and review this is a closer look around the risk 006, which is on page 41 of the pack, which relates to primary care. So when I was sort of looking at it with a bit of distance and with fresh eyes, I did reflect that at the moment it's focused on Fuller and implementation of Fuller, and I'm aware that it's not just Fuller that's setting the framework for how we would expect and would want to support primary care to be able to respond, and to also have the resilience, picking up on the workload point that Jeff made earlier, to be able to support us in everything that we need to do as a system. So I think when we come together, it'd be really helpful to have a look at that and reflect on previous conversations around primary care and the challenges that are there, to see if there might be value in reframing it. And then particularly I'm just reflecting on the fact that the risk score, it's doubled, hasn't it? So the target risk was 8, we're at 16. There's 4 of the 5 mitigating actions delivered, but it seems to have got worse. So it might be in between those points we could actually review where we are and if there's anything else that we needed to do with the current focus to move it forward.
Yeah, so I that was a point that was picked up in our executive meeting. We did have some discussion around this particular risk, so I do think it's something that we'll bring and have the fuller discussion on in the board session.
Thanks, Sam. And Jim?
Thank you. 2 or 3 comments. The first one is to agree with Sam basically. I think this is now embedded, and it's we've moved on a lot in terms of the Board Assurance Framework. 12 months ago, we couldn't say in our annual governance statement that this was properly embedded, and it was commented on by both the internal and the external auditors that we had further work to do. I think a lot of that work's been done. It's not completely done, but it's moved on a lot, and to the point where it could have been mentioned by Kevin in the achievements over the last 2 years. Actually, I think it's that big a deal really. So that's extremely helpful. The area that we don't do when we look at the Board Assurance Framework, though, is to review how we're progressing in terms of delivering the strategic objectives. And I think we need to have a conversation at some point about looking specifically at each strategic objective and the extent to which it's being delivered. So not just focus on the risks, but focus on what we're supposed to be delivering, which I think is at least as important as focusing on the risk personally. And the third point is around the risk policy. That's been through the audit committee. we sort of agree that it should come here as a document for recommendation, for approval. I think it's actually a really good document. There's a lot of things in there that people can use as references when they are looking at risks, including, I particularly refer to item 18, which is appendices on the risk scoring matrix. We will be talking over the next few meetings about the risk scores and so on. That almost sets out the basis upon which we should be scoring risks. So it's quite an easy document to follow in lots of ways, but it's also makes it very explicit about how we should be scoring things. So there's some subjectivity sometimes comes into assessing risks. That makes it quite an objective process. So I would commend that particular page. But there's other bits in there which are equally helpful from a reference perspective.
Thanks, Jim. I mean, this consistency of scoring is really, really important, and also the, you know, when you look at in the heat map, I mean, unsurprisingly, everything's in that upper right-hand quadrant, with 2 risks in the 25. So if we're scoring at 5 out of 5, it is going to happen, and it is going to be dire. And then on both of those, we say, yeah, well, we scored at 25. The target's to get to 15. But I think we which I'm not going to do. If we go around the board table, people might have a different interpretation. So at 25, have we already lost it and it's happening? Or 25 is no. If we do the work to get to 15, we'll avoid that or not. So there's a question about the what it means. And 25 in that box is the most extreme. That's one point. The second is on your point, Jim, which is about consistency of scoring. Some people will be more enthusiastic and motivated around the risk management frame and the connection of the board assurance framework to strategic priorities. Others may see it more of a requirement to do rather than something that helps them manage the business better. What's the filter that we have to get that consistency?
Yeah, so I mean, all really good points, and thank you for all the comments as well. I think you're absolutely right, and that was a key sort of observation, I think, when we came together as execs, that this is the level of maturity we're at the moment. This is the stage we're at. We've got everybody owning their own risks and looking at that and bringing it up and scoring that through their own lens. But we've never, until this a few weeks ago, really looked at that across the board and said, let's have a proper joined up discussion around that. And that's the next stage to come to the board in April. But in doing that, I would have today changed some of the risk scoring on here, but we didn't want to do that before we've had the board conversation, because I think when you do that and you bring a much more balanced, consistent approach to that scoring. So that is an essential part. And I think every year, certainly as long as I've been a finance director, in all of the roles that I've had in the past, there has always been an annual opportunity to do that as an executive team and as a board, to say, what does this look like? Does it feel right? Because it's not, a process can help you so far, but some of this is about really us knowing our business and knowing, how does this feel in light of that? Have we got it right? What's coming up on the horizon? And that's sort of consistent. You can't do that through an individual lens. So I think that is the process I'm describing.
Thank you. Chris, how does this work in your board?
So I think this was one of the things that was pulled out in the Care Quality Commission's report into LSCFT around that robust governance from risk level, from ward and team level, right the way up to board, and then back down. We have a risk management group that's set up that reports into our committee and up into board. For me, I think it's making them live. It's making them feel that there's actual purpose behind it, I think, which is really important, which I think comes out in this document. And it's good to hear Jim say about it being embedded. I think that's, for me, is a key milestone.
That's the key bit, isn't it? Thank you. Tracy?
Thanks, Chair. Yeah, I sort of look at this and wonder if what we're talking about is organisational risk, or when we look at some of the risk indicators, they're much wider than that. So, you know, I think you've talked, Sam, about people owning their own risks, and that sounds very organisational focused to me. And maybe that's what we're trying to achieve. But I'm just thinking about across an integrated care system, are we missing some of the things that we're doing, particularly around some of the mitigations? I mean, I'm just looking at one of the indicators here that talks about the cost of living. There's a huge amount of work that's happening at local authority level and voluntary sector level that are mitigating some of the things that are impacting on poor health and well-being around the cost of living, yet they're absent from this. So I don't know if that is actually part of this. Are we looking at organisational risk, or are we looking at that wider system risk where maybe some extra work with other partners would enlighten us a bit more as to how we're mitigating it on a much wider scale?
Sam?
Yeah, I think it's a really good point and something we probably aren't looking at the moment. We've been thinking about the executive team, thinking about the board, but I think your point's really valid. And what's really important is when you're looking at these, it's what are the gaps in controls and what's happening and what are the deliverables against some of these things as well. And sometimes we may not be aware of all of the things that are happening in the way that we should be. So I think we need to give some thought, and I'll pick it up with Deb about, you know, how do we, and with Kevin about how do we maybe think about some of the partners in the system-wide bit. I think it's always been that challenge, hasn't it? When we started looking at our approach to risk, it's this different dilemma that ICBs have now, that they're not one statutory organisation on their own that have that with those three levels of risk we've talked about before. So I will give some thought to that and pick that up and come back to you on that.
Thanks, Sam. Any other points? We're asked to approve the risk management strategy and policy 2024 to 2027. Is there any more information anyone wishes to highlight on that before we approve it or consider approval? We content to approve, please. Thank you. Well done, Sam. Very good. Let's talk integrated performance report, Asim.
Thank you, Chair. And I think we'll start off with, I think Kevin's already alluded to some of our positive performance in the Chief Executive report. So just to firstly remind the board, the metrics contained in this performance report are discussed in various forums within the provider organisations and within the structure of the Integrated Care Board. And in large part, the contents of the report covers statutory performance reporting, part of the NHS oversight framework. The paper also contains the latest performance against the key headline metrics, which was our second half of year submission that we put forward to NHS England. The report contains data from a period of December and January, which as always is extremely pressured and challenging. And for this year, I think it was further challenging because of the industrial action taking place over this period. And I would like to take this opportunity to thank and acknowledge the commitment of our frontline staff across our system who have worked tirelessly over this period. They have shown commendable resilience and dedication. I will take the report as read, and I would like to focus on the key headline metrics as I've sort of alluded to before. So urgent care, some real, I think, positive sort of story here really in comparison to the national and northwest positions. So the ambulance handover times in January were better than planned, although category 2 average ambulance response times saw a slight deterioration on the previous period but remained quicker than national averages. Overall in January, 4-hour performance A&E across the ICB was 74.6%, and just for context, the national performance was 70.3%. The northwest position was 67.35%. So in summary, our A&E 4-hour performance remains in the top quartile in England, 6th best place out of the 42 ICBs. Bed occupancy did rise over the winter period, in line with national levels. However, we did see a fall in 12-hour waits and reduction in 60-minute ambulance handover delays. Moving on to elective care. In the elective care domain, our waiting list, pleased to say, across Lancashire and South Cumbria dropped for the second consecutive month in November and December. So we now have 253,696 patients waiting for treatment, which was a decrease by 3,350 patients, a decrease of 1.35%, which is in line with the national level. But nevertheless, this is still a significant way off the number of patients that were waiting before the pandemic, which were approximately 120,000. So double the amount of patients are still waiting. And at that point, there were very few people waiting over 52 weeks. Most patients were being seen within 18 weeks. All providers have submitted their plans to deliver 78-week waiters by the end of March. However, there are some risks associated with these plans, especially in services like orthodontics, gynecology and gastro services. So yes, the plans are still there, and we are working very hard to get to the 078 plus week waiters, but there are some pressures, specifically in orthodontics. The final area covered in the key headline metrics is cancer. And just to remind the board, on the 17th of August, the NHS England announced a change to cancer waiting times, which saw a reduction from 10 standards to 3 standards. Just a quick reminder to the board, the 3 standards are 28-day faster diagnosis standards, 31-day decision to treat to treatment standard, and the third one is the 62-day referral to treatment standard. Really pleased to say, as a system, for the first time since we changed to the 3 standards, we achieved the 28-day faster diagnosis standard. And this standard is really important because it ensures patient with a diagnosis, or has a diagnosis of cancer or has cancer ruled out after being referred urgently by their GP for suspected cancer. We continue to perform better than North West and national averages on the faster diagnosis standard. A bit of a mixed position on the other 2 standards. On the 31-day decision to treat to treatment standard, University Hospital Morecambe Bay has met the standard once more in this reporting period. But our 2 other providers, 3 providers, have not met the standard. But we do meet or slightly higher than a national average on this standard. In relation to the 62-day referral to treatment standard, we remain below the North West and national averages, and none of our providers are meeting these standards. As I said, this is a mixed position, and we have a comprehensive cancer improvement plan which includes reducing diagnostic delays and increasing surgical capacity. So them are the key areas in the key headline metrics, but before concluding, there were some 3 areas I wanted to draw out from the report. First one being the annual health checks for people with a learning disability. And in December, we were below national trajectory on this. The final quarter historically is where a lot of these annual health checks happen. And looking at the latest figures, we are comparable to where we were last year. And this is, sometimes we have these reported to us, but this is a really important metric because people with a learning disability often have poor physical and mental health than other people. And as a result have a shorter life expectancy than the general population. So this is a really important metric. The latest figures are showing that we are in line to meet the target of 63% out of the 75% target at the end of February. Secondly, in relation to mental health, again, this is positive. The talking therapies, previously IAP, focuses on planning improve access to psychological therapies in order to address enduring unmet need. I think for a long time this has been in the bottom quartile performance, but we saw this reporting period, this has now moved out from the bottom quartile performance into mid-quartile nationally. So real good progress, and I think this starts showing that we are meeting the needs of our vulnerable population. The last area is children and young people vaccination. And we've seen there has been increased prevalence of measles in other parts of the country, and it's good to see that our population vaccination coverage is higher in our ICB than the North West and national averages for 2 doses of the MMR vaccines. So I'll leave it there, but before concluding, just want to advise the board, we are refreshing our integrated performance report and our performance framework. And health inequalities reporting will be an important feature of the integrated performance report. As I mentioned at the last board, the NHS England statement on information on health inequalities identifies a number of areas that the ICB and provider organisation will need to report on. And one area of focus is elective recovery to ensure there's inclusive recovery. And this is the area we have done some really good work on. So we're now able to understand the size and shape of our waiting list by ethnicity, deprivation, gender, and other factors as well. And I'm sure there'll be opportunities to bring some of that learning back to this group and other subcommittees. So I'll pause there and happy to take any question with support from executive colleagues in relation to their respective portfolios. Thank you.
Thanks, Asim. Yes, start with Sarah, please.
It's a comment really, Asim. Thanks for the report and a really clear summary. I suppose I just wanted to comment on two areas. One was the vaccinations and the measles, which we had quite a robust discussion at Quality Committee about this. And I suppose, and the other was the learning disabilities health checks. And I suppose on both, I want to maybe make the same point. And I suppose it's a word of caution for us as a board, and it's picking up really on health inequalities, because whilst overall you've given us a level of reassurance about the overall statistic, I know we've had at least one case, Abdul will confirm, of measles, it might be two. But I think the discussion on the Quality Committee was, whilst overall our vaccination rate is reasonable compared to other parts of the country, what that overall statistic is masking is some of the communities where that rate will be really low and where the children will be more vulnerable for other reasons. Who don't get their health check. So it's just to really make the point, and we are doing some work on the quality of the learning disabilities health checks, because we focus a lot on the tick, they've had a health check, but our learning disabilities team are finding that the quality of those health checks is also variable and not where it needs to be. So I just really wanted to caution us a little bit, not to, I suppose, rest on our laurels with some of those statistics.
So I think that's really good, Sarah. And in the last Finance and Performance Committee, we did some deep dive on some of the inequalities, and one area was around vaccination. And what was really clear is the difference in vaccination uptake in different areas of our community, especially in ethnically diverse communities and deprived communities. And so that's the kind of absolute reporting that we need to get into. Hence the introduction of inequality reporting will give us a much better lens to look at these data from.
Thank you. Yeah, we discussed health checks for patients with learning disabilities at our first meeting in July 22. And if we'd said at that time, okay, where do we think we can be in 21 months' time, in March 2024? Anybody who said 60-something%, we thought that's a bit weedy, wouldn't we? And you're right, it's getting below the aggregate that's key in understanding that.
Maybe I can just comment on that. And we did say, I think, that we are going to schedule to come back to board about having a focus on learning disabilities and autism, but we get the LEADER summaries at Quality Committee, and LEADER is the national programme around learning from deafs with people with a learning disability. And really, sadly, we're not shifting the dial on outcomes. So in a way, the health check is just a process, isn't it? Have they had a health check? What we should be really looking at is the outcomes for these people, and particularly mortality. And we're not actually shifting the dial on some of these things. And I think probably now we're maturing more as a board, as Kevin's report said, is I think we do need to start probing a little bit more into the impact of some of what we're doing and the actual what that means for population outcomes.
Thank you. We've got Abdul and Jeff.
Thank you very much, Chair. Really just picking up on Sarah's point regarding measles. There is a measles group which is chaired by James Scattergood from the ICB. It meets every Friday in terms of an IMT, in terms of planning and preparedness and response. It has directors of public health, really, as well as our ICB colleagues on there, amongst other stakeholders. I think in terms of Sarah's point, really, there have been 10 cases, lab confirmed cases across the Northwest. The main cluster is still within London and West Midlands. However, really, we have had notification now, really, of a number of cases within our footprint within East Lancashire in particular. And there is obviously a lot of work in this regard with our ICB as well as NHS England and UXA colleagues. I think Sarah's point is valid, really, in terms of the actual response at local, at place level, and the resources that are required for our inclusion groups. And I think that's my main point, Chair, really. We do need to reach into our GRT communities, rural traveller communities, our homeless and refugee populations, but also the populations really clearly where we need to do some further work in terms of this issue. And so I think that my supplementary point would be that alongside measles, we're also finding that the overall vaccination rates across the country have actually dipped post-COVID, have not recovered sufficiently enough. Whooping cough is another one really where vaccination levels are not where they are optimal, and therefore is resulting in kind of outbreak situations. So I think there's a lot of work to be done really within primary care on a long-term basis, and any funding and support at place level would be highly welcome. Thank you.
Thank you, Abdul. Jeff, measles in Barrow?
I was going to talk about measles again and about learning disability. I'm sorry, but I think they're really important in this report. I think it would be remiss not to say this, being a public meeting and being a public body, about getting the message absolutely clear. I've had measles when I was a kid. It was absolutely horrible. It was the worst thing I can remember from my childhood. I've seen a child die of measles a long time ago. I don't want to see it ever again. It is, I think Abdul would say, it is the most communicable of diseases, and it is either horrible and can be deadly, and lots of damage, deafness, brain damage, etc. So I think the public need to be completely aware of what it is, and that vaccination is very safe and very effective, and all the fears about it inducing autism and the like are completely discounted now. There's absolutely no evidence base to suggest that. It's very clear, I think. So that's what I want to say about measles, just for the absolute clarity for the public. That the thing about learning disabilities in primary care is I don't think it works very well at the moment, and I find it very hard to do when I'm working in primary care. And I think practice do, which is why I think it ends up being done at the end of the year, just before the figures are counted. So I think it needs a bit of a rethink. I'm not being critical of my colleagues here. I think it is difficult to do, and to do it well, because I think a lot of people do it but maybe not do it well, is to be able to identify issues and then get resolution of those issues for the individual concerned, rather than just tick a box. So I think we need to have a think outside of a board meeting about what we could do to make it more effective.
Yeah.
Thank you.
Thank you. Sarah, can we take that away? Pick that up, please. Got Roy, then Chris.
It's on that particular subject, Chair. Thank you. We were at a meeting recently in Blackpool. I was at a meeting in Blackpool where the Director of Public Health there was referring to the issue of measles. And he was suggesting, and in fact he did, and he copied me into this, a letter that he wrote to his members of staff in early years, social care, and some of the council staff to encourage them to be vaccinated against MMR, certainly because of the risks, I think, that's associated with that. And I might be wrong on here, but I'm sure Abdul will tell me if I'm right or wrong, but I think MMR vaccines were only brought in the late 60s or something like that, 69 maybe, I think it was, or maybe, was it?
Sorry, Jeff, when was it?
It was after I started practice, so it must be the sort of mid to late 80s, I think.
Well,
before that we did measles alone.
Okay, if that was the date then, certainly there'll be people who didn't get that vaccination, so I think it's really important. Perhaps we could think about just sending out a note to our staff who work within those particular confines to encourage them to ensure that they've had that vaccination, because as you particularly said, Jeff, it's a really difficult infectious, and it transmits very easily. So I think it's important. I think that people are aware of that. If I could just come back on another point, Chair, if that's okay with yourself, with regard to the actual report, and thank you, Asim, for the report. And I'd just like to say, as Chair of Finance and Performance, that report has improved significantly. We're getting so much more information, and I very much support the inclusion of inequalities being in that report. I think it's important. We had a discussion at the last Finance Performance Committee about that, as Asim's alluded to, but I think it's really important that we include that in the information that we're getting within the integrated performance report to the board, to make us aware of the position. But the point I was going to ask about was the virtual ward and the capacities within that ward, capacity versus utilisation. And we've got some figures within the report there that show the utilisation, which is relatively low, and certainly low in some areas. But I think I'm not sure if these figures are the up-to-date figures. I'm sure I've seen higher figures in terms of utilisation of these particular beds, but I think perhaps in terms of discharge and you know and getting people out of hospital and not using intermediate care if there's no availability, that it's really important the virtual wards, the virtual beds that we have, and that capacity is used to its fullness. Thank you.
Thanks, Roy. Chris. Oh, sorry, Jeff. You want to come back?
The dates, according to Google, was it was developed in America in the late 60s, but used in the United Kingdom in the late 80s, I think.
I was nearly right then. Thanks, Jeff.
Thanks for that, Jeff. Chris.
Thank you, Chair, and thank you, Asim. It was just to pick up on one point in the performance report on one of the areas where LSCFT is not doing well. There are a few around out of area placements, and we talk in the paper, and but I don't think anybody around this table would forget that these are individuals that are transferred way away from Lancashire and South Cumbria at a time when they're really at crisis point often. And so there's just three things I wanted to bring up, if that's okay, Chair. Just one around the work that the Trust is doing about reducing length of stay, and some of our longest length of stay, and we've reduced that by over 50% in the last couple of months under the work that Dr. David Fernley's been doing as Medical Director. The second would be Worley and the previous Calderstones estate over by Clitheroe, and we take transfer of that whole estate on the 1st of April, but we have opened 3 mental health inpatient wards on that site already, and the last one just opened last week. And then finally is joint working with the ICB around a risk share for out of area placements, and I think that's really key, because it gets bought in from both the organisation but also from the system and from place. And there are a number of people that are either homeless when they come into mental health inpatient settings, or are made homeless as a result of the length of stay in hospital, and I think tying that into place and place leadership is really key. So really looking forward to working with Sam taking that forward.
Thanks, Chris. Excellent. Anything you want to say in response to any of the points I see?
I don't know, Craig, if you've got anything to say about the virtual wards. Okay, I think that's fine.
Okay, thank you. Good report. So in the previous item on risk assessments, we had 25 on operational performance. It just shows the point that someone made then about an aggregated score across a whole range of some things that are going very well and some things that are more challenging. There's been a bit of publicity this week. I don't know if it's gossip or fact, that there's some financial incentives for trusts to see 76 out of every 100 people within 4 hours, and you get. Is that right? And are we going to perform well enough to get any of that money, Craig?
We've just had a letter about that, Chair, that relates to stretching your target to over 80%. So it's not about delivering and it will only be the top 10 trusts who have gone above the 80% that will receive 2 million each. So it's not for everybody who does the 80%. If someone pips you at the post in the league table, then unfortunately you won't have access to that.
Okay, thank you. Will Blackpool be in this?
Blackpool are one of our best performers.
Yeah.
They won't be getting 2 million.
Okay. It's interesting if we go into a phase now of last minute incentives to try to get the right side of a line on something, isn't it, really? It'd be very interesting to see how that policy is reviewed in due course. Okay, good report. Thank you, Asim. Well done. We move on to the finance performance report, Sam.
Thank you, Chair. Okay, so this is the finance report at the end of January, so 10 months into the year. As the board will be aware, the system planned to have an £80 million deficit this year, but that recognised that there was quite an ambition to deliver a whole raft of sort of system-wide recovery programmes, which needed longer to embed into the system to enable that plan to be met. The key thing, I think, when we're looking at the finances and we're looking at that sort of recovery approach. I think it's really interesting listening to Chris talk about the OPEs and the flow in mental health, and it's exactly the same story in acute care as well. So when we're looking at patient flow through the system, what we're seeing with some of the pressures that we've got are really around where we've got sort of very, very highly pressured emergency departments, and again reflected in mental health as Chris has described. So a big part of the recovery is going to be all the work that we've been talking about, engaging voluntary sector, engaging place, engaging all of our partners, local government, in how do we unlock some of that both at the front door and at the back door of that sort of flow for our patients. So I think this is where we can do this, but it takes time. So unfortunately, for when we're looking at month 10 this year, some of those ambitious programmes that we've got, there's some really good progress, and Maggie's team have started some of that work that's really going to set the scene, the clinical view, the longer term blueprint and what we need to do. But it does take time, and unfortunately this isn't that, you know, the position that we're seeing today isn't that nothing's being done. In fact, we've actually delivered over 400 million across the system of savings, of QIP savings, SIP targets in trusts, and also a number of non-recurrent actions to help us to get through this year. But it's just not enough in terms of what we've been expected to do to be able to meet that £80 million plan. So as at month 10, the position's a 208 million deficit, and we're doing everything we can to land 198 million by the end of the year, which is the plan that we've got. So that's 59 million in the ICB and 139 million across our providers. But there is a 30 million risk to that is well versed and reported through to our regulators around that position. So if you look at the trajectory going forward, looking towards from now to the end of the year, we're probably heading towards that 250 mark. We will bring that back down, but I don't think we'll mitigate the full £30 million risk. So that's where we'll probably land. The good news in all of this is because of the work that has been started in year and the good work that's been done right across the system by everybody in it, we are, and I think, Kevin, you mentioned this in your report at the beginning, we are starting to see a real stabilisation. We're starting to see that run rate slow down and the whole time equivalents that we talked about. I mean, when we're talking about staffing as well, and I know Kevin mentioned some big numbers at the beginning, a lot of this relates to huge amounts of agency and bank and agency staff. This isn't about a lot of permanent staff. This is about relying very much on temporary staff, which from a quality perspective isn't good either. And so this is about reducing this, and we're starting to see that slow down. So I think as we see that, the next part of the challenge will be, how do we tie this now into recovery going forward? How do we make sure we're focusing on those things going into early next year that not only stabilises but starts to bring those costs down? And that's what we're focusing on now. But I'm happy to take any questions on the report. It is where we are at this stage in the year, but I would say there are a bit more than green shoots, but things coming through that are indicating we're going in the right way, and we just need to make sure we're carrying on focused on the right things going into the next year.
Thank you, Sam. I mean, it's clear from your report, Kevin, and from Sam's more detailed report, it's very tough on this, but there's clear signs that improvement is now being made. Jim?
Yeah, thanks. I think the point Kevin made before about no surprises. This report, there's no surprises in this report. You know, it's the culmination of all of what you've been doing for a number of months. So I haven't actually got any comments on the revenue side. I think it's very consistent with the stories we've talked about previously in this board meeting. What I was going to say about the capital expenditure. And the capital expenditure is we've currently got an underspending on it. So it's whether we're going to spend the allocation in year, and if not, whether we've got plans for handling that between years, basically.
Yeah, so there's a lot of work going on across the providers predominantly in this space, and there are a number of things being looked at to see what, particularly around the backlog maintenance and things where we could bring things forward. So I know those discussions are going on, so we're going to try and land this as close as possible to the year, and it's not a huge amount off at the moment, but we're going to try and get that as close to the allocation so we don't lose that opportunity, because as you know, capital is really tight, so we don't want to lose any opportunity not to have that money, particularly for some of our high backlog maintenance schemes which we could bring forward.
Thank you. Roy, I'm a bit out of sequence here because the committee reports come further down, but while we've just gone from performance to finance, is there anything from the Finance and Performance Committee that you want to escalate into this meeting?
I'll bring it up later, Chairman, on those reports, as you rightly say. And I've said this before at the board meeting. Some of the things that we've discussed in Finance and Performance Committee are superseded, I think, by the issues that compound some of those things. So when we're reporting back on the escalation report, on the AAA report, I think, to the board, I'd like to see us give as a much clearer and up-to-date position, which Sam gives in the financial report. And the word, I think, that was used there was stabilisation. And I think we are now actually achieving stabilisation within those discussions. So some of that reporting that I'll be doing later from the Finance and Performance Committee is absolutely correct and rightly should be there in terms of audit reasons and a trail that I've discussed those things and I've reported them into board. But as I said, some of those things Sam has already concluded that we're in a different position now. We're stabilising. We're seeing the green shoots of recovery, and I think that's absolutely right there because we've had some conversations about that just recently. But I think I could conclude, Chairman, from that it's been difficult, and we have actually, I think, as a board, discussed finance very robustly, and you will have seen earlier in the BAF report, we had a score of meeting statutory financial responsibilities of 25. We've discussed that before in the board. We recognise that as the highest score that could possibly go. So that is recognising the issues that we had and the problems that we were having across not just the ICB but across the system itself and within the acute trusts. So I will come and I will report back from that. But I think it's important to say that we are on the road to recovery. I think that's really important. Thank you.
Thank you. Okay, noted. Any other points, questions? Okay, so would you I mean, look, 18 days till the end of the year. You wouldn't expect any significant move on any of these numbers between now and the end of the year, Sam?
No, we're obviously continuing to mitigate risk, but this is, what I'm saying is that 30 million is the key risk.
Yeah, okay, thank you. Got it. All right. Recovery Transformation Programme, please, Maggie.
Thanks, David. And I think because both Kevin and Sam and others have alluded to some of this report already, my update can be somewhat briefer than I was expecting. I think the paper is here to update members in a very high level of the work and how we're progressing. Kevin has gone into some of the detail around some of the schemes and the areas that we've been focused. The beginning of the paper reminds us of the context of the work that we are committed to, improvement, and that being sustained improvement in health outcomes for our communities. And I think that's a really important point that I can't stress enough. All of the work streams that we've got now that are aiming both for transformation, for how we will look in the future, but also contributing to the recovery in the way that Sam's just outlined, are about how do we improve the experience both of our staff and our patients and our communities as quickly as possible in a very sustainable way. 1.2 in the paper highlights that we do have a responsibility to provide value for money, and as Sam has very clearly described as part of her paper, £300 million worth of temporary staffing spend in my book
does not provide us with value for money, and it certainly doesn't always enhance the quality and the experience that people who are using our services feel. So the paper outlines the key areas in which we are working, the clinical strategy and what will we look like in the future. It's predominantly got two major areas of focus, and in the paper we talk about that in a very high level. So we've got community out of hospital transformation, and that includes both mental health, learning disabilities and acute conditions, and also we've got our a hospital transformation programme, which again is inclusive of both mental health, learning disabilities and acute conditions. We also want to do that transformation with an eye on what will we look like and how will we be providing services which all of our regulators find satisfactory. I think we can't possibly bring a detailed report to each of our public board meetings on the level of granular detail which is now emerging. As you can see in the paper, there is work stream and sub work streams, and really a plethora of papers now. Those papers we intend to see both in our sub board committees, quality and finance and performance as appropriate, but also we've got our recovery and transformation board which has met monthly, chaired by David as chair of the ICB. We did say when we set that committee structure up last autumn that we would review its effectiveness after 6 months. And as I depart now, I know that's an area that Sam's going to be looking at. How effective is that? Is it delivering for all of us what we expected? And how can we actually improve the way that we are reporting? So we haven't gone into war and peace in the paper in relation to all of the work streams. And we did touch on this in previous meetings, and I think it was touched on earlier by a colleague. The opportunity to go into board seminar on the whole recovery programme and go into more granular detail is something that I now pass to Sam. Can't actually do it myself with moving on to Blackpool, but I think it would be really helpful for colleagues to be able to have a really good look at the comprehensive nature of the work. But I'll pause there, David, if that's okay, and happy to take questions.
Thank you. Just good paper. Any points, questions? Pending a deeper look into all of this together in due course. Okay, thank you. Receipt, well done. Right, the ICB committee's issues for escalation. I'll go through one by one. If I may, Sheena, can we start with quality committee, please?
Thank you very much. So what we've got here is the AAA reports from two meetings. One is the 24th of January, the other one is the 21st of February. I'd just like to pull a few things out, particularly from the alert areas. And what you'll hopefully see in looking at these reports is the way that we're very much now starting to work across our committees and also up to board. So if we reflect back into conversations we've had about the finance and performance, you'll see that with the addition now of Sarah coming on to the finance performance, we're starting to take that integrated approach to all the different areas that look at how we're getting value. And when I mean value, what I mean is actually getting the best outcomes we can for the people that we serve. So I wanted to just pull out a couple of things, and the first of those is really around some of the things that are creating some concerns and alerts, but being clear that there are mitigations being put in place. The first of those is around what we've noted in our quality and safety report is some quite a large number of unplanned closures of pharmacies. So that clearly has an impact and may have some impact on inequalities around some of our more rural areas. So the board is clearly asking the primary care committee to actually start to think about that in greater depth and think about how we might mitigate some of the risks of those. You'll also note that there are some issues there in relation to dental access, and again that's something that we have considered previously at the board and clearly is now needing some further focused work on. In relation to safeguarding, we clearly have, as a statutory responsibility as a board, a number of different areas, and we felt, having had our discussion at Quality Committee, that we perhaps wanted to spend a little bit more time in a future board development session on taking a bit more of a more deep dive approach to looking at safeguarding and SEND. There are lots of positives going on in those areas, but there are some further areas that we do need to look at, particularly in relation to our children in care and our health reviews, and actually thinking about how we can work even more effectively across the system and between statutory partners on a number of those areas. Then the final area I just wanted to look at in terms of an alert from that meeting in January was around the 2 Regulation 28 notices, which is in relation to some work in across, again, agencies around response from ambulances to some particularly difficult situations, and how, again, we need to look about how we address some of those even better joint working across our urgent and emergency care pathways. In relation to other areas, I just wanted to mention on that was around we did look from an assurance point of view in quite a lot of detail at that meeting about maternity services, and particularly looking at the work of the local maternity neonatal system, and actually ensuring that we've got that oversight, and also that assurance around things closing the loop on things being taken forward. The second meeting that I wanted to just update the board on was around the work that's going on in terms of the it's just jumped out. Thank you. I've got it written down here. Was around paediatric hearing improvement programme, and members of the board may not be cited on this, but clearly paediatric hearing is one of our it's a very important service, but often doesn't get the scrutiny that it really needs, because it's small numbers, but you can imagine in terms of the impact for children and families in not getting that service properly provided, has a huge impact on people. So we were very pleased to have a very comprehensive feedback around the work that's going on about improvement planning in this area, and whilst there are still areas that need to be looked at, I think we were very pleased to see that there's a lot of work going on, and a clear improvement plan in place to look at both the experience but also access for children and families to that important service. We have got some continuing work about our patient safety incident response framework, and we know there is a transitional issue about the backlog of serious incidents, and we want to take some further time as a quality committee to get assurance about how those can be further mitigated in speeding up those reviews. And then finally, I just wanted to mention the work that's going on in terms of our Never events, and a workshop that took place across the system to look at how shared learning and work can be taken forward on that. Then I just wanted to take us to the cross-committee work, which is really important, which is at the bottom of this. You'll note that this is the kind of point I made at the beginning, is about it's important that we work together as one rather than in silos across our committees. So I wanted to take you down to the bottom of the report, which is takes what we've raised from Quality Committee into other committees, and in particular I mentioned about the maternity services and our review of that and the work that's going across the system in that. And this is really about, and it goes back to this issue about fatigue that we talked about earlier, and I think it's important that we note that we need to seek to understand how we support our staff in the most effective way. And we picked up from those reports about some concerns about high levels of sickness in maternity services, and actually asking the People Board, and Jane chairs that, and she might want to come back to that in her bit, around actually thinking about how we can even better support staff members from a wellbeing perspective in that area. Thank you, Chair.
Thanks, Sheena. That's excellent. Jane, linking to you now. I'll come to you next, please.
Thank you, Chair. Yes, we didn't. There's no AAA report from the People Board because rather than a formal meeting, we had a development session in January, and this was in response to feedback that we'd had from members and from the Audit Committee that we needed to review the purpose and functioning of the board. And Lee led a very positive, engaging session with members of the board. And what became clear was that a lot of the confusion was around, is the People Board a committee for workforce issues of the ICB and or workforce issues across the system? So we had a good discussion about that. And I think what emerged that we're going to present back to people in March is that the People Board needs to be a system-wide board that is strategic rather than operational and is looking at what are the workforce challenges needed to deliver our 4 key purposes around addressing health inequalities, improving population outcomes and so on. So in terms of health and care integration, new ways of working, working differently, working as a system. So we very much want it to be focused, you know, accepting that it is about workforce issues for the ICB, but we want very much the focus to be much more system working around themes around one workforce and bringing people together to work collaboratively with a really kind of strong ethos on partnership working. The idea is, because there's so much potential you can talk about when it relates to workforce, is that we'll have the main board and then we'll have some subgroups looking at different themes, one of which, you know, will look at health and well-being. So it may be that we ask, you know, the board and then the subgroup to particularly look at pockets where health and well-being is particularly bad. But we're looking at what the system can do around that. What's the joint offer in terms of a kind of wellbeing offer across the system that might mitigate some of those problems? So trying to always bring that sort of perspective to it. So we see the main board being an overseeing strategic body with subgroups looking at different aspects of workforce issues. They are likely to be themes around workforce transformation, culture, careers and training, inclusion, health and well-being. Those are some of the themes we're looking at for the subgroups. In March, at a follow-up development session, we're presenting some of this back to participants and also revised terms of reference and membership, and then looking at the composition of the subgroups and what they're going to be working in terms of priorities. That capture it, Lee? Great, thank you.
Thanks, Jane. Next to Debbie, please. Public involvement and engagement and Primary Care Commission.
Thanks, David. So in terms of Public Involvement and Engagement Advisory Committee, or PIAC, there's a summary from the 28th of February meeting. So there's nothing in terms of alert, but there's a couple of items for advise and assured that's just helpful maybe to highlight. So against alert, we spent time having a look and an update against the Recovery and Transformation Programme that Maggie's just helpfully updated against. And I think it was recognised within the committee that there's huge value and huge opportunity in embedding the approach to engagement and involvement throughout that whole range of work streams. So there's some excellent practice already there around service reconfiguration and service improvements around vascular, head and neck urology, but there was a real appetite and ambition to make sure that it's embedded across all that activity, because it's so important that it achieves the improved experience and outcomes that Maggie touched on before, and PIAC can give support around that, taking it forward. There was an update against primary care involvement and engagement, which was really valuable. The feedback that we looked at was sort of feedback through the national survey findings and also some local intelligence. So at each meeting we receive an update against complaints and other areas of insight, and we tried to bring that together because we'd not looked at primary care, I think, for a year. And what came through really strong was that the things that are most important from a patient perspective, and there's no surprise there, we've just drawn it out, is ease of contacting the surgery, ease of access to appointments, convenience and consistency of care and treatment. So it's a really clear message that's coming through when we try and triangulate all the different pieces of insight. The action against that was to review it with the primary care team and to also consider how the feedback through engagement and involvement could come through at a future ICB board meeting where we're going to look at primary care so that we can try and distill all of that information in one place. We reviewed and can offer assurance against the co-production and engagement work around maternity and neonatal. So we picked up on the conversation that had happened in board, and we received an update against that for assurance. And we recognise specifically that the oversight of that sits within Quality Committee, so it did touch on how that oversight will work, and how engagement and involvement will contribute to that in terms of sort of the assessment of impact and outcomes. And then the only other area just to quickly draw attention to from an assurance perspective is a place deep dive that was delivered by Blackburn with Darwin colleagues. So we have representatives from each of the places who sits on PIAC, so that we can embed, learn from, encourage and support best practice being shared across place and throughout the system. So as always, fantastic insight into what's happening in that place and what's most important and how the principles are being applied around good practice. And there's some work there really about how we can support or contribute to learning from that best practice both within the ICB and across the system and across place, and try and make that more systematic when working with colleagues. For Primary Care Commission Committee, there's two sets of AAA. So there's one from 18th of January, one from 8th of February. So again, there's no alerts, but in terms of advice, 18th of January meeting, there's an advise and also an assure against Withnell. So the decision around the future delivery at Withnell is obviously a keen item of interest and importance to our local community. So we've updated in the AAA that at the January meeting we received an overview of the significant engagement and involvement group activity that had been delivered to help the ICB understand what's most important to patients at that practice and how their views on how future delivery at the practice could be shaped for most value from their perspective. And we also took forward a request for information, which we said that the decision would need to come back at a future Primary Care Commissioning meeting, as we were awaiting some legal advice that unfortunately hadn't been received and so couldn't be fully considered to support robust decision making. And that's coming back to the next Primary Care Commissioning meeting, which is tomorrow. 8th of February meeting, just to flag, because it links through to points that other colleagues have made, we considered the primary care dental care prioritisation framework, which is coming through as a dental commissioning plan, which will again come through to tomorrow's meeting for consideration and for approval.
Thank you, Debbie. Excellent. Next I'll go to Jim, please.
Thank you. At the Audit Committee on the 25th of January, we had an update on mandatory training, and you can see that we are, at that point, we were slightly below as an ICB in terms of the mandatory training level, but work was underway to meet the target. In respect of this year's accounts, because of the financial position we're in, we're going to get, as it's described there, as a qualified regulatory opinion on the accounts. It will not be a qualified set of accounts at this point in time, but there will be a statement in there that there is an element of qualification in effect. So that's inevitable because of the deficit we declared, and we reported that to NHS England a few months back. We had 3 completed internal audit reports, one of which was only limited assurance, and that was in respect of QUIP, and that was primarily around the systems and processes underpinning it, and the fact that it was not felt to be sufficiently organisational wide in terms of the drives behind that. It was mainly being driven by finance, and everybody else should be playing into that was the recommendation. All the recommendations that were in those reports are being followed up. We are specifically at the Audit Committee later this month going to see how we are doing in terms of following up on audit recommendations. At that meeting, it's not mentioned in the AAA report there, but only something like 46%, or I think there was 46% of recommendations were still outstanding, which felt like a high number. So we're going to review that at this next meeting. The risk management policy we've talked about in this board meeting, we approved it there, and we are likely to get a limited assurance from the head of internal audit, moderate assurance, which compares with limited assurance that we had last year. So that the internal audit people are happy with us in terms of governance than they were 12 months ago. I know you would like it to be higher, but it's going in the right direction, basically.
Yeah, thank you. I mean, I don't. When we say moderate assurance, the thought bubbles rub people's heads. Half of them think this is improving. Half of them think this isn't very good. I mean, nobody around this board table goes out the front door in the morning aiming to be moderate. What's the what's the path that we're on with this, Jim? What needs to be there to get a higher level of assurance?
Mainly history, actually, and the track record, and we haven't got history or track record. So they build it up; it accumulates over years. By year 4, I would hope this organisation would be much higher than moderate. At that point, if we're only moderate, then I think we need to be pretty highly critical. But last year they had very little evidence of systems or processes in place. In the year we're in now, we're seeing more internal audit reports come through and more assessments of the systems and processes, most of which they're saying are fine, some of which they're saying further work is required. Next year, that should move on again. So I think we'll see a better position next year. But it is basically a track record, and inevitably, we're not 2 years old yet, so we haven't got the track record required to get a better opinion than I think they're giving us at this point in time. I'm assured that no other integrated care board has got a higher opinion than this, or certainly none that Mersey Internal Audit Agency are linked with. So, and they think we're ahead of the other ones in the northwest in terms of governance systems, processes, and so on. And I know, you
say
made
that
the
to all the ICBs.
Well, I doubt it. But, and I know you've said in the past we shouldn't take comfort from that sort of thing.
Yeah.
And I don't. But I think we have moved forward. I think there's clear evidence we've moved forward, but there's also clear evidence we've got work to do.
Yeah.
So it seems a reasonable assessment of where we're at.
Okay, thank you. Understood. And Roy, you've already mentioned 1 or 2 things out of the committee. Anything else you want to say?
Yeah, thanks, Chair. This is from the 29th of January meeting of the Finance and Performance Committee, but I just wanted to sort of comment on the earlier comments I made. The approved minutes that you have in your papers today are actually from the 18th of December. And at that 18th of December meeting, we actually discussed month 8 data. We've heard today from Sam month 10 data. So there's going to be a difference in that reporting, I think, to this board. And I think perhaps it's something we need to think about, how we report the up-to-date data that we have through our committees. So that's just a point I would just make on my earlier comments. With regards to the actual AAA report, you can see from the alerts there the financial outlook, and that's something we've already discussed and heard about. Recovery and transformation, again, we've heard from Maggie, and we're expecting an update to our next meeting regarding that position. On the advisory part of that AAA report, we had a long discussion at the committee about the role and purpose of that committee and what we need to focus on. We agreed and decided that we had been looking at sort of transactional reviewing of past performance, and that's what it says in the report. And I think that's really important to let the board know. We want to be more of a forward-looking committee, I think, in terms of finance and performance. And subsequently to the meeting of that committee, we have met with officers of the ICB, the non-executive directors of that committee have met with officers of the ICB to discuss future emphasis that committee might discuss. And I think that was really important for us to do that, because we were discussing things that we couldn't change, and we were hearing things, that were being reported to us, as I just said, finance, in terms of finance month 8 data. But we're not going to be able to change those things if we can hear them at the Finance Performance Committee. But things we are able to comment on and change are things that may well be coming to us when we're talking about future direction. So I think it was more about the future direction of that committee, and particularly of the organisation, that we wanted to discuss within that particular committee. As you can see from that AAA report, we talked also about the integrated performance report that we received from ASIM, which I said at the time that was we all agreed that that was a good report, and we commended it, I think, to this particular board. And the last part that I'd just like to refer to on there is the need for somebody to bring a commissioning perspective. So we did agree to co-opt the Chief Operating Officer, Craig, to our committee, to the Balance Report Performance Committee. We've had some good discussions, I think, recently about commissioning, about how we can take that forward into next financial year. We seem to forget sometimes when we're a commissioning organisation, you know, we don't perhaps have enough discussion around that particular subject. And I think that we, as a committee, can bring some of those conclusions, I think, to the board about commissioning. It's clear we need to hear those as well at board level, but I think commissioning has a direct impact on our patients and our outcomes. So it's really important that we discuss those within that committee, but also as a board. But we were asked to approve that proposal to co-opt the Chief Operating Officer as a co-opted member of the F&P, Chairman.
Thank you. All very clear. Good work. I think we are getting into a good routine around the connection between the work in the committees and how that shapes board agendas and discussions here. So thank you to all the committee chairs for that. We now have a short break and then come back for a suite of important items through to close the meeting. So if we could sit back down again by 2:55, please, that would be great. Thank you. 24-25 ICB high level draft budget.
Thank you, Chair. Okay, this is the, I guess we're in March and we've got to bring a budget to the board, but it's still very draft, as you can see. We actually are still waiting for planning guidance this week, but having said that, we're pretty sure of most of the components of that, so we're not expecting any major changes, and we have been made aware of allocations and assumptions and so forth. But we are still finalising the positions. But I think we need to bring a budget paper here because we've obviously got April on the horizon and people need to start working to budgets. But what that means is there's currently a planning gap in the paper. So I need to be clear that it is draft and that conversations are still being held with NHS England, as we've yet to identify solutions or obtain support for that remaining gap of 95 million. So the board is going to be asked to approve the draft on the basis that those discussions still need to be concluded and a solution identified in terms of the position, because as we're all aware, we can't plan to spend more than we've been allocated as an ICB, so we just need to be clear on that. The paper does take the board through the allocation for 24-25 with a 4.4 billion allocation and shows the breakdown of that. There is a small element, as always, probably less than in previous years, as there's been a number of items now put into the recurrent baseline, but there is still a small amount of, well, it's 90 million of non-recurrent funding, which you can see the breakdown of in the table in the paper. A final plan of both the ICB and the provider position is due to be submitted on the 21st of March following the final planning guidance that we're expecting, and provider positions are also still being finalised. So the planning assumptions are provided in table 2, so people can see what assumptions we're making. And a point to note is that inflation, again, going into next year is expected to be running higher than the level at which is funded through those assumptions. And particularly in light of things like prescribing and CHC. And that continues to place pressures on the budget, which is why part of that pressure that we're seeing is being driven by the fact that there is pressure in there. But we do have a high number of mitigating actions on top of the normal quip in there to try and address as much of that as possible. As always, mental health is being protected in there through the Mental Health Investment Standard, and what isn't reflected in here is any review of contracts. We are doing our commissioning intentions at the moment, and they're still being reviewed. So there isn't any big contract reductions planned in there. This is all about the ICB's mitigations and actions to try and drive down some of that pressure. We might be able to also look at some of those inflation assumptions, and that's part of the work we're doing at the moment, because we do know the GDP inflator is reduced and we are expecting lower inflation, so we're looking at those options as well. But we've got more meetings coming up over the next week with NHS England to finalise the position. So what I'm asking for is for, obviously, any comments and questions, happy to take, but then I'm asking for the board to approve the draft budget subject to the things that I've mentioned, and I think we probably need to be clear that that draft includes finding the ultimate solution around the 95 million planning gap.
Thank you, very clear. And will the approval at this level make expenditures from 1st of April legal, won't it?
Yes, it will, yes.
Yeah, okay, thank you. Questions, Jim, first.
Yeah, thanks. I suppose as someone with a finance background, I don't feel naturally comfortable just rolling forward a budget of £4.something billion. What we're not seeing in this, I suppose, is any kind of change in strategic direction. We're not seeing some of the things we talked about in the Recovery and Transformation Programme coming into kind of direct focus. We're not seeing a move from acute to community section and so on. And whilst I don't think we can do it now, we are where we are, and this is what we've got to do. I accept that, but I think we need to kind of agree to do a little bit more work on this in the coming 12 months, so that when we're at this stage next year, we've got more understanding of what's going into each of those budgets and the extent to which we could be or should be moving money between budgets, and also whether we should be financing any kind of service developments, for example. So there's no obvious service developments in this budget as it stands, and I realise we got to get something approved approved just so we can start to spend money on the 1st of April. But it just feels like in the background for next year we need to do a bit more work basically.
Yeah, so there are a number of investments that we always have in there, but you're right, we're not moving money between budget lines, and that's the bit about the contract review, commission intentions. There's nothing big tied into here from recovery at this stage. That will be the plan going forward, but we are still investing in the things that we were expected to invest in, so things like primary care and the quality contract and the SDF funding. There's a number of investment lines in there that will continue to, but what we're seeking to do more and more as we've been developing some of our sort of processes and our ways of working is ensuring that for all of that it is impacting in the right places that we would want to see. I don't mean just financially, but it is driving. So for example, primary care quality contract really driving some of that admission avoidance, frailty assessments, those sorts of things that will impact on some of the pressures we talked about earlier in acute care. So we are doing some of that, but I would agree that it is probably more amount around the margins and not any big plans around recovery at this stage.
Thank you. Any other points, questions? Angie, please.
Thank you. This might be something to take offline, but I think I share some of Jim's concerns in terms of, as a board, we're being formally asked to sign this off to legalise the expenditure, which I appreciate. But it may be that we need a more private bit of advice about what our responsibilities are as board members in this regard. So, for example, if we didn't agree with the planning guidance and we felt that was maybe, I don't know, for example, an unrealistic expectation of inflation, what are our responsibilities in terms of signing off the figures? Equally, I'm very mindful that the forecast gap here, accepting everything that you've said about the caveats, is very similar to how we started at the beginning of this year, and we're just talking about a 200 plus million deficit plus a risk factor in there. So I think I would welcome just a little bit of guidance about our responsibilities as a board, which we might want to do in private session. Because I'm deeply conscious that in local government our obligations may be very different, so I might have a set of expectations on my responsibilities which aren't quite right. But if we could have that perhaps in private, that would be helpful.
I think it's a very good suggestion. Thank you. We should do that. Okay. Just one from me. Sarah, can you just give us a flavour of of the sort of quality impact assessment of a 37 million reduction on the all age continuing care spend, how that works and how you got to a place that this feels okay?
Well, it's always a bit chicken and egg, this, isn't it? So in some ways the figure has risen more from what we need to do because of inflationary pressures and that to kind of fit with the allocation that we've got. However, the team, and I suppose in one ways it's probably an easy one for me to answer than some of the other areas, because of the massive improvement work on all age continuing care over the last 12 months, a lot of what we need to do going into next year is a continuation of programmes that are already there. So actually the team have very quickly been able to work up quips for next year trying to get to that 37 million, and actually it's a team that have woven in QIAs and EIAs all the way through. So as they've worked up those CRIP schemes, they have done the QIAs and the EIAs. We have got a process that was signed off by Quality Committee, so they have been through Quality Committee and have been signed off. And actually, because as you know from Sam's other reports, there's still probably quite a lot of the opportunity in this area is probably still about working closely with local authority colleagues around how we manage the market and a better price for some of the care and aligning ourselves with local government. And so some of the opportunity here is more about being more efficient and more effective in how we're managing all age continuing care rather than having to decommission something. And I was nearly going to do it on the Bath but I suppose I'll do it here because it's really a acknowledgement, a bit like Kevin's year acknowledgement of the team and the work that they've done, because if the board remember over about 18 months, starting with the need on that settlement with local government on some historic cases, then the business case that I brought through on the need for significant investment and the ROI. But if you remember, I think at the time I talked about a 4,000 backlog of reviews. We have got no backlog reviews on all age continuing care as we sit here today. They've gone. We've got no fast track delays. Our incomplete referrals, there's none over 4 weeks, whereas previously we had some over 12 weeks and even longer. And we are going to hit our quality premium again this month and this quarter that we've set with NHS England. So actually, in terms of QUIP, which is also about quality, innovation and productivity, we have improved the quality. And actually on the bath, if we didn't have the financial challenge because of inflation, the volume of packages and the price on them, we would have hit the target risk score on the all age continuing care work this year. It's just we've kept the risk high because of the financial challenge, and it's such a big spend of the ICB. So to answer your question, actually they've done it relatively not easy, but it's the QUIP work on all age continuing care will just be a continuum. Now it is a big stretch, so you set us 21 million last year. The update I got yesterday, Sam, is they're now within less than $1 million of that, so I think we have got 20 million of those savings in the bank, and we are still very well. We are going to hit the rest at the end of the year. So it is a big stretch, but we've now got the team. A lot of those savings came halfway through the year when we in-housed the team. So hopefully it will be a stretch, you know, and I think it's important that the board around prescribing and CHC, which is our biggest area other than contracts for us to go at as an ICB, they're big asks we've got of the teams, but the quality impacts are all there, signed off.
Okay, thank you. That's good, and obviously the numbers that you'll stick close to as the year starts and progresses. We content then to approve the high level budget. Thank you. Urgent and emergency care recovery and winter update, Craig.
Thank you, Chair. So this is a regular update that I bring to board throughout the winter period on our urgent and emergency care recovery and winter performance. I'm going to take the paper as read, and actually the first couple of sections in the paper Asim did cover in his performance report about our trajectory and performance. The information I've got, although it's not validated yet, is that we are just over the 76% mark last week. We had a bumpy ride in Preston over the weekends, but we're recovering well so far to date, and I am confident we're going to get over the 76% by the end of the year if everything keeps going according to our current expectations. Equally, there is a level of confidence from MWAS that we will meet the trajectory on the CAT2 targets. We do perform good in relation to NWAS. There is challenges because it's an aggregate position across the Northwest, so it depends on the performance of some of the other ICBs, which obviously is without of our control. Just in relation to this update, we have had a letter from NHS England in January advising us that we are expected to meet that 76% target, and advise us that there are some key initiatives that we should discuss with our providers, which we did, and nothing that would surprise anyone around this table: streaming and redirection, rapid assessment, maximum use of urgent treatment centres, improve ambulance handover, and reducing time in the department, which were all a part, I'm glad to say, of our improvement journey. They also offered some opportunities in relation to online integrated masterclasses, virtual drop-in sessions, and some support improvement packs, which again we took up that offer. So that's something that the Trust have been working hard on. In addition to that national letter, we've also had regional support on a weekly basis to report into region on our performance, and we were asked to relook at our trajectories, and as I said, we are on target with our resubmitted trajectories, and they asked us to consider the top 3 initiatives for 4-hour improvement. Those were alternatives to the emergency department, as we've just mentioned, workforce and estates. In addition, under 4.3, you'll see I asked for another number of elements. So developing 2-hour urgent care response plans, implementation on flow improvement plans, and just picking up Roy's point earlier, maximum use of virtual wards. Our virtual wards range from 20 mid 20% utilisation to high 90%. There's real variance across our patch. We have a virtual ward improvement plan that did see some improvement to over 60% as an aggregate position, but that was mainly due to the ones that were doing really well, doing better. So we do need to review our virtual ward offer for next year, and that's a part of our UEC strategy and plan. Finally, NHS England is reviewing our tier 3, which is our lowest level of intervention. Anyone who is teetering on the edge of the performance is being reviewed, but I feel that compared to systems that are in tier 1 and 2, we are rightly in tier 3 at the minute. I think the proof will be in the pudding on our performance at year end, but again, that's a level of confidence I've got in the system as long as we continue to keep our foot on the accelerator with the plans. Finally, there's been a number of workshops to look at our investment funding for winter for next year, and there's a further workshop this Friday, of which then a paper will be going to our executives and the relevant committees to think about what our potential urgent care strategy will be for this year. And I've asked the team to look at our global UEC funding, so not just the additional amounts we get, the amounts that are in all of our departments, including mental health. We have had some challenging difficulties, another round of industrial action. We did unfortunately see some 8-hour breaches in relation to waits for ambulances, which obviously is of a quality concern. And we saw a couple of very, very long 150 plus hour waiters in our A&E department, which again we're doing root cause analysis on, and those will be reported to quality committee. So that's been a very challenging time, and I've met with all the chief operating officers about remedial action plans for those concerns. I'm going to pause there. What we've included under Appendix A is just a bit more, I think it was Jim's point last time, understanding our 10 high impact interventions, the key for the maturity matrix, and some notes on where they are in the priority. So that's an additional element that I'm happy to take any questions on. Thank you, Chair.
Thank you. Jim.
Yeah, thanks. Thanks for the paper, and I know we said last time we'd done really well, relatively speaking, over the winter period, so I'm not going to go back on that. But when I look at the performance, I still think it's really very scary. You look at the earlier when in our SEAMS paper, we looked at the percentage of people in type 1s who are being seen within 4 hours, and it's just over 50%. It's really not good. And the number of 12-hour waiters, so 76% may be the national figure, or 80%. It's still, if you're the patient waiting that length of time, this is still not a good performance. I've got an observation and a comment, really. The observation is in respect of a statement which the risk of losing the tier 3 status remains the highest risk in relation to urgent and emergency care. I'm thinking that's an administrative process. How have you wrapped that up? That's an administrative process. The risk of emergency care is people not being seen, or being seen, treatment being delayed, or whatever. There's so many bigger risks than us losing an administrative process, I think, in urgent care. So I absolutely disagree with that sentence, I've got to say, and I think that should be amended. But my question is about, and it does relate to the 10 high impact interventions. Acute respiratory infection hubs, we've got 0 against all of this, and I'm thinking that means presumably that means we're doing next to nothing on it, which strikes me as worrying. So perhaps you give us an update on what we are doing on acute respiratory infection hubs, because they would have a big impact if we had them in place.
Thank you, Jim. And just on the first point, I think the risk of going into tier 3, there's a huge amount of criteria that impacts on number of delays, patients waiting in the department, and there's turnaround. So the risk is if we tip out of tier 3 into 2 and 1, that's because all of those elements have deteriorated. So I can explain that in more detail in a future report. I absolutely take the point about the administrative process. It's not about that. It's what would drive that process to tip us into tier 2 and 1. The acute respiratory infection hubs are very prescribed. We haven't got any that meet the guidance, but we have virtual wards that do respiratory infection support, and we have some services in UHMB specifically that look at the respiratory element. They just don't meet this particular high impact criteria, so that's how we report 0.
Virtual wars are primarily after the event. This is post the event. This is admission avoidance stuff, isn't it? This is to stop people coming in primarily.
Well, there's a mixture, yes. So, but we don't. When you look at our acute respiratory infection hubs and what they're designed to do, we don't currently have them.
We'll pick it up in the Finance and Performance Committee meeting.
Okay. Thank you, Sheena, please. I'll get to everybody.
Okay. I just wanted to say that clearly there's an awful lot of really good work going on in this area, and I think really want to commend all our staff across the whole system, not only in hospitals, where obviously we're focused in terms of it being seen the pressure, but also across all services. And it is very challenging, and recognise the really good work that people are doing. And I think this is really important as we look forward to this year about what our priorities are in recovery and transformation, because clearly in terms of if we really start to look at the value here, and I mean value in its big broadest sense about the outcomes for people, their experience, the safety and the effectiveness of what we do, focusing on this collectively I think will benefit enormously, and then also help with the recovery bit and the financial bit. So I think it is thinking about, as we move into this year, how do we have some one or two things that we absolutely as a system agree we're going to land and do that we know have the biggest, highest impact. I think the final thing, just from a bit of personal experience, which I won't go into over the last few weeks, what I've observed is the huge inequalities that everybody is in a challenged situation when they go into the emergency system and urgent care system. But what I've observed from is the fact that unfortunately that impacts on our most vulnerable people in society. So if we can get really into this and drive into this even more collectively, we'll make a big difference right across our quadruple aim. So I think I just wanted to emphasise that point. Thank you.
Thank you. You mentioned 2 patients, if I heard you correctly, who basically spent nearly a week in the emergency department. Will those cases on how all that was managed come to the quality committee?
Yes, so we've asked for root cause analysis to be conducted and then it to be reported through our quality committee.
Okay, thank you. Tracy, please.
Thanks, Chair. I would just want to pick up on something really positive, Craig, that I'm seeing happening around the urgent and emergency care developments and the capacity building around that. I think, I've sat around this table and have been in various forums for a number of years, and we've been saying as a sector, a voluntary sector, for a while, can we please be at the beginning of the conversations when the planning is taking place around this? And I've really seen that through these developments since probably that first workshop last July in Chorley, at Chorley Hospital, and then what happened on the 6th of February, and of course what we're going to be doing on Friday. I think, that acknowledgement of some of the solutions around admissions and discharge are within the voluntary sector, that we have an awful lot to bring to the table. I think the acknowledgement's always been there, but what I've really seen is that action around that recently to really engage with us as a sector. I'm hoping that some really good co-produced solutions are going to come out of this, and that we can actually start shifting the dial a little bit in the way that we've talked about in terms of investing in ways in which we can avoid people turning up at ED when they really shouldn't be there, and obviously help people when they're medically fit to leave hospital to go back to their homes. There's an awful lot of good work that has the potential to grow, and I think you're really well aware of that, and I think many people around this table are. So yeah, I think it's really positive what we're doing around that at the moment, and I've got my fingers crossed that some of the outcomes are really going to come to fruition.
Thank you. Well said, Tracy. Anything you want to say by way of conclusion, Craig?
Thank you, Tracy, and we made a real conscious effort to involve as many of the partners, the places, our local authority colleagues, because we believe the solutions are beyond the front door, and in fact a lot of them sit within that community provision. So thank you for that, and I just to agree with Jim's point, I'm not complacent about these figures at all, and I do think that we need to see that improvement trajectory, absolutely, and a huge thank you to the staff, because I've been doing the industrial action now for over 12 months, and it is quite exhausting for everyone involved, as well as managing winter. So a huge thank you to all of our provider staff. And finally, I'd just like to say that I think the proposal would be that we'd stand down the winter reporting from April, but we would replace it with a forward look for our urgent and emergency care strategy and how that will play out over the forthcoming months in preparation for next winter. So I'll take that offline, Chair, if that's okay.
Yeah, of course, thank you. And sorry, my peripheral vision let me down. I couldn't catch you, Roy, but you come in the last word on this.
No, I'll be very quick, Chairman. Thank you. Recognising that MWAS are an important part of our winter strategy, and we are now obviously the lead commissioner for MWAS. I think it's perhaps important that we have a little bit of information imparted to us as part of, I'm not sure if it's this report or even your portfolio, it probably is, Craig, but I think it'd be interesting to see some of that as the lead commissioner. I think it's important. Thank you.
Yeah, I'm happy to bring up a report on that, maybe to Finance Performance Committee or here, depending on the suitability.
Okay, thank you. Good. Let's move on. Emergency Preparedness, Resilience and Response, EPRR.
Thank you, Chair. So I'm here presenting this in my Accountable Emergency Officer role on behalf of the system. So this is a report that updates our current assessment and the check and challenge process undertaken by NHS England with regards to the core standards for EPRR, which is obviously the Emergency Preparedness, Resilience and Response, and our subsequent improvement plan that we've put into place following that assessment. And not to jump to the end, but for those who have read it, the assessment is not great. So I just want to start with that and hopefully build on it. This was a new process that was implemented by NHS England, and it did have a huge amount of rigorous analysis and evidence and compliance requirements that were very stringent against each core standard. That's not an excuse for where we are in relation to our compliance. It's just an explanation of we shifted from one assessment framework to another. We have developed a robust action plan in response to the current assessment, which I'll update you on. Just to say, in way of context, we're now a Category 1 responder. The CCGs, of which 8 of them were not Category 1 responders. So there was a difference in what we were assessing ourselves previously on and what then we're required to assess ourselves on. And for local authority colleagues, this will be very familiar, but it's about our responsiveness under the Civil Contingencies Act. And there is a whole different set of requirements under that act than previously. So that's why the core standards have changed. When we were assessed, we weren't the first region to go and undertake that assessment. The Midlands had undertaken it in 2022 as a pilot. That resulted in significantly different assessments of the self-assessments and results, ranging from 7% of organisations declaring compliance to 30%. So we had a similar picture then that was applied to the North West. And as a part of the learning event with NHS England, we reflected and said it might have been helpful to take more of that learning from the Midlands and apply it here. We might have been able to prepare our organisations better for what those differences would have been. So they did recognise and acknowledge that. So as you can see, the core standards, so there's 47 standards applicable to the ICB, and initially we said we were compliant fully with 37 and partially compliant with 10, and we've got the overall compliance assurance ratings there under section 2.4. Once that had been reviewed, actually that came back with fully compliant of 5 and partially compliant of 42, so a huge difference. And under section 2.6, I've shown the difference and the variance in the self-assessment and the compliance across all of us, all of our providers. So you can see the variance ranges from 60% to 77% from self-assessment to the NHS England assessment. Just to illustrate this with an example, so I'm the Accountable Emergency Officer. That is now in my Chief Operating Officer job description. My job description had to go through a formal process as it would do. When we submitted, because it hadn't been formally signed off, although been agreed by the Chief Exec, it wasn't compliant job description. So, and therefore, you can't get compliant on that. So that's just to give you an example of the absolute stringent nature of this. If a policy said it was to be reviewed in July and they assessed it in July and it hadn't been reviewed, it wasn't compliant. That's the level of detail we're talking about. However, we were going through, and again, this is no excuse, huge amounts of industrial action last summer. So that was an added complexity to the strain the team was under, and the team wasn't fully recruited to. But nevertheless, it is a poor assessment. So I have asked the team to work on an improvement plan to take us from the non-compliance rating for this year to either a substantial or fully compliant. So we've now recruited to a full EPRR team. We've had comprehensive training for our tactical and strategic on-call. We've done a training needs analysis for all of the and personal development for all of the staff on call. We now have a robust rota in place that's about to be reviewed. Again, that's a part of the improvement plan. We've reviewed all of our business and continuity policies. We've got further ongoing training, and we've developed a risk register. So we've put all of this in place since the self-assessment. And we've asked all of our trusts to take their self-assessments, which I'm sure Chris can comment on, through their own governance and report back to us in our oversight group. We have included the plan in Appendix B as well, and happy to take any comments on that. And just under, from section 2.10 down, we've described some of the updates there in relation to our providers. NHS England have not yet announced the plan for this year's core standards, and we are expecting this will be an ICB review-led process, except for us, which will be an NHS England one. However, we're working on the basis that it will be another full NHS England one, so I've asked all of the providers to update on their action plans in due course, Chair. Thank you.
Thank you, Craig. Maggie, you've seen more of these things come and go than popped in. What do you make of this one?
So I was going to put my hand up to contribute, and I think it's so disappointing, and I felt really sad when we were going through this process. But I would say, how many incidents have we had, or how many SIs have we had in relation to events that have been managed through the EPRR process? Now, I know that could be false reassurance, because it could just be that the holes in the cheese haven't aligned yet for us. But I would ask that, are we seeing significant concerns raised by other agencies about our handling? And we have had multiple events that we've had to manage through being a Cat 1 responder, unidentified World War II bombs to right through to the industrial action. So I don't think there is a trend or a theme there. Could be false reassurance. However, we have had consistent positive feedback from our regional EPRR colleagues in the way we've consistently managed above and beyond other parts of the Northwest. So I think we have to take this as an absolute wake-up call that if it's not written down, it didn't happen type of mentality. We have to have the evidence behind everything that we do. However, we have not had significant impact because of that. Far from it. We continue to get good feedback about how we do, but we can't rest on our laurels. And as Craig has said, I'm really satisfied with the amount of progress that we've made since these standards have been introduced.
Thank you, Chris. What did you make of this? There's a 77% difference between your self-assessment and the post-panel review.
Yeah.
Do you thank them for that post-panel review?
Absolutely. I think taking Maggie's, I think it is a bit of a wake-up call. You know, I was the accountable officer for this when it was submitted in my previous role, and at that, you know, there would have been a lot more greens. To take Craig's point, it is a lot. We had an awful lot of non-compliance around policy dates, but again, that's not acceptable. And we need to own that and resolve it. So I think, yeah, and a bit like Maggie, you know, on Christmas Day we had a major fire in one of our inpatient units. It was handled from an EPRR perspective impeccably. So yes, is it false assurance? I take a level of assurance from the processes and the systems that we've got in place, albeit there is still significant room of improvement.
Thank you. And Jim?
Thanks. This doesn't seem to have been our finest hour in terms of the submission. But I was also going to make the point that it would be very worrying if we didn't have evidence that we've handled incidents well. So it feels like we do handle incidents well despite this. The question I've got, though, is around the action plan, and there's so much to be done in April, the month of April. And even though some of them may just be being compliant with dates and so on, it seems a massive task to do all the things you said you're going to do in April. So how realistic is it that you will comply with Appendix B on this?
Yeah, so I'm confident we will complete all of that in April. We've had to manage some of it. It was due to be in March, but with industrial action June, we've had to move some of that. So some of it's about adapting. We don't want to go delay further into the new financial year, but we've had to respond to, we can't do all of this when we've had, because industrial action, even though it was over 6 days, there's 2 days leading and 2 days post industrial action, so it actually takes us out for 10 days. So some of it has had to be revised, but I'm confident we will complete all of that based on what the team's reporting to me.
That's good, thank you. I've got Abdul and Maggie.
Thank you very much, Chair. I'd like to highlight a piece of work that the UK Health Security Agency is actually doing with the ICB in relation to multi-agency control of human infectious diseases and the actual plan. So just to reiterate, really, there is work ongoing. Obviously, it's pertinent in the light of obviously the MMR issue and obviously the measles outbreak situation is a national incident. But if we could expedite that plan, Craig, I think that would be enormously helpful as part of the assurance process that we've just described. Thank you.
Thanks, that was very helpful. Maggie?
Yeah, just a quick comment back on Jim's asking for how do we feel, how assured are we about the action plan? And I forgot to actually say, you know, for the first year of our life as a new organisation, this team was 2 people and we had copious amounts of industrial action. It's now a team at full strength and they are a really good team. I know how bitterly disappointed they were when we got this report, and I would like to convey my own personal thanks for how they've supported us throughout all of those incidents. So I'm positively optimistic. If you get time, Jim, when you're in, just pop your head into their office. They're a really good, small but perfectly formed team now. So I think we are going to see a catch-up.
Thank you. Okay, so we approve the action plan. Look forward to reporting back on that. Let's talk about the annual review. Strap yourselves in for this. The annual review and publication of conflicts of interest register.
Thank you, Chair. So this is all about our openness and transparency. We've got the annual review here, and it's all of the publications of the conflicts of interest registers are all now available on the website, so they're all there for you to look at. I have to say big thank you to Deborah and her team, because there's a significant activity been done over the last few months to make sure that we update and keep on top of this. It's now mandatory training from April around the conflicts of interest, and we're rolling out a programme as part of our mandatory training, which starts in April, to update all of our staff around this area. I have to say, if you do look at some of the documents and go in and see, you'll see things like registers of hospitality and other things where people are not just recording when they've accepted gifts and hospitality, but where they've declined them as well, which is really good, positive action. The only other point I just wanted to raise was, under this is an area that our internal auditors have reviewed in detail, and they have given us substantial assurance opinion on this area. Thank you.
Thank you, Sam. That's better than the moderate you got on the other stuff, Jim. Sarah?
Thanks, Chair. It's not really directly about this, but I suppose it's a question I had for us. Wasn't sure whether to bring it up here or not, but it's similar theme but slightly different. So I suppose it was just, I'm conscious that about 2 weeks ago a new leadership competency framework for board members was published, particularly for chairs, CEOs and board members. And I suppose it was how are we gonna look at that as a board, and what do we need to do? Because I think there's some real specific asks, particularly for those of us who are members of boards, linked into appraisal and things. And so I suppose it was just in case other people weren't aware about that framework. I think it was the 28th of Feb. It was published.
Thank you. Yeah, just to add, Sarah, so that's very much linked to the new framework around fit and proper persons. So we were expecting the guidance or the competency framework, and there'll be an appraisal framework for chairs and an appraisal framework for executives. We're still waiting for the executive framework. So for this year, NHS England have extended the time for this annual cycle of fit and proper, and that's very much part of it. So we'll be looking at doing appraisals for that look back over June, July, August to the new competency framework, but there's elements of fit and proper that come into that, and we have to submit to regional director by the 30th of September, which will be signed off by the chair.
Thank you. Received. All good. Use of integrated care board seal and approval of a special payment.
Thank you, Chair. So very quickly, it's just reporting to the board on the activity around the seal, which has been used twice since it's last reported. The only other thing to point out on here is there is a special payment which I am asking the board to approve. So under special payment guidance, we under our SFIs and our scheme of delegation, we do have to have any special, whatever the value, going up to 95, I think it is, comes to the board for approval. So I'm asking for support for a damaged laptop approval of just over £1,000 to an individual, and there's a whole process that's gone on behind this which I could give you updates in detail on, but I can give you assurance that it's right and proper that we do need to support this payment, and I'm asking for the board to approve it.
Okay. Thank you. Approved. Are there any items of any other business, Kevin?
Yeah, in typical David Flory style, I think I won't say very much, by the way, you've rightly wanted to focus on the business and avoid any discussion of yourself. You can't get away with that completely. So just on behalf of the board, want to note your departure. With the Ides of March approaching, congratulations on your relegation to the Liverpool University Foundation Trust and the Liverpool Women's Hospital. I have to advise you won't be getting a parachute payment. And also, we'd like to formally thank you for your leadership, support, calmness under duress, your humility, dignity, expertise in the art of looking ahead and round the corner to navigate complex NHS politics, and your mastery of the art of understatement. As an example, when the chair says that's okay, it means good. When he says it's good, it means it's outstanding. And when he says it's outstanding, he means it's out of this world. And we've had a few of those, actually. And finally, thank you for your sharp wit, which has been on display abundantly today, and your penchant for fashionable ties. Thank you, we'll miss you, and stay in touch.
Yeah, thank you very much. It's been great, and everybody who's around this table has been a great pleasure to work with, and everybody around the table has contributed to the business here being better than it would have been if you hadn't been here. So thank you all very much indeed, and I know everybody will support Roy in the same way that I felt, and all the best for the future. Thank you.